Hello, my name is Dr. James Galvin, a professor of neurology, psychiatry, nursing, nutrition, and population health at New York University. And today we're going to go over an overview of dementia. This module is available online. It's developed by the Hartford Institute for Geriatric Nursing at the New York University College of Nursing. Let us review some of the objectives of this module. We're going to discriminate between healthy brain aging, mild cognitive impairment, and dementia. We're going to develop strategies for evaluating and following older adults for cognitive disorders in the busy office setting. We'll understand better the potential value of biomarkers to improve our diagnostic accuracy, and learn about non-pharmacological approaches to help manage the neurobehavioral symptoms associated with dementia. So what exactly do we mean when we talk about healthy brain aging? Well, healthy brain aging is the absence of symptoms of cognitive decline, and this can occur well into the 10th decade of life. Now, as older adults age, they can have a number of physical limitations, but in this case, we're really speaking about cognitive limitations. Older adults with healthy brain aging can still carry out their everyday activities and lead productive and happy lives. With age, it does take longer to do things or to recall information, but it usually comes back. For example, people may take longer to balance their checkbook, but they're still able to do the calculations. Or it may take them longer to recall a person's name, but it does come back to them. Memory loss, however, is not part of the normal aging process. So what is dementia? Well, dementia is a general term. It means the change in memory or other thinking abilities that interfere with everyday social or occupational functioning and is not caused by another medical or psychiatric disease. Dementia itself, though, is a syndrome. It's not really a diagnosis, as there are over 100 different causes of dementia. It's important to understand the different causes of dementia because many of them will have different approaches to secondary and tertiary prevention as well as treatment. You can see from this slide there is an extensive differential diagnosis of dementia. The most common causes of dementia are the neurodegenerative diseases, particularly Alzheimer's disease, which will be the main focus of what we're going to talk about during the day. But there are other causes of dementia, including Lewy body dementia, frontal temporal dementia, and the vascular dementias. The other disorders are much rarer and unlikely to be seen in the setting of a typical office practice. The most important thing to recognize is when somebody looks like they're developing a dementia and it's something outside of the usual picture you see with Alzheimer's disease or vascular causes of dementia, then one of these rarer disorders may be occurring. One of the important concepts now is that dementia is not an absolute, so people don't go from being normal to not normal. There typically is a transition period, and this is referred to as mild cognitive impairment. Mild cognitive impairment, or MCI, represents a change in cognitive abilities. You have to have both objective findings, that is, you test individuals and they're having an impairment in their cognition, and it should be endorsed by either the patient or by an informant who knows the patient well, such as a spouse or adult child. Generally, people with MCI are independent in their activities of daily living, although there may be some decline in their performance. For example, they may still cook meals, but have more difficulty preparing complex meals. MCI is thought to be a prodromal stage of dementia, although rarely it may be reversible. What is Alzheimer's disease? Well, as I mentioned before, it is the most common cause of dementia. In 2011, the Alzheimer's Association estimates there were 5.4 million Americans who have Alzheimer's disease. While most of these individuals are over the age of 65, approximately 250,000 individuals will be below the age of 65. These are typically referred to as early onset cases. The total cost of Alzheimer's disease approaches $172 billion annually. This would put it at the third most expensive disease after cardiovascular disease and cancer. Alzheimer's disease is also the fifth leading cause of death in the United States in individuals over the age of 70. And Alzheimer's disease makes up 50% of all nursing home beds. Let's review some of the risk factors for Alzheimer's disease. By far the most prominent risk factor is age. For every 5-year age group beyond age 65, the percentage doubles. So at age 65, the risk is about 8%, and by age 85, it's 42%. Family history may also play an important role. Although most cases of Alzheimer's disease are sporadic, if people have strong family histories of the disease, it may increase their risk. Early onset cases are more commonly going to be associated with a family history and may be represented by rare mutations that make up 1 to 2% of all cases. If if an individual has one of these mutations, these gene mutations are fully penetrant and people will develop the disease. Fortunately, these are rare. The late onset cases probably are a combination of genes and environment and represent common polymorphisms in the genome. Gender may play a role, as Alzheimer's disease is slightly more common in women than it is in men. The reasons for this are unknown. There are also a number of life exposure factors that may play a role in developing Alzheimer's disease. For example, head trauma, either a significant head trauma associated with the loss of consciousness, or more recently there's been information suggesting that repetitive minor head injuries with concussions may increase the risk for Alzheimer's disease or other forms of dementia in later life. All of the cardiovascular risk factors, high cholesterol, diabetes, hypertension, obesity, also appear to be very strong risk factors for the future development of Alzheimer's disease. And finally, a lack of intellectual stimulation and educational attainment may increase the risk of Alzheimer's disease. Let us quickly review the criteria to define what Alzheimer's disease is. These are taken from the Diagnostic and Statistical Manual, or DSM-4-TR. Realize that the DSM-5 will be released in the next year, and some of these definitions will change. But at the present time, the DSM-4-TR criteria requires the development of multiple cognitive deficits manifested by a memory impairment plus a disturbance in one other cognitive domain. The cognitive deficits cause significant impairment in their social or occupational functioning and represents a significant decline from a previous level of functioning. Again, this is important. Memory plus another domain that interferes with ADLs and general functioning and represents a significant decline from a previous level of functioning. The course is characterized by a gradual onset and continued decline, although the rate of decline will vary by individual. The cognitive deficits cannot be due to another condition and do not occur exclusively during the course of a delirium. Lastly, the disturbance is not better accounted for by another axis 1 disorder, such as major depressive disorder or schizophrenia. In 1984, the National Institutes of Health and the Alzheimer's Association came together to define a criteria for the diagnosis of Alzheimer's disease. This required abnormal results on cognitive screening and neuropsychological testing. The deficits had to be in 2 or more cognitive domains. There was a progression of the memory deficits and other cognitive deficits over time. There was no disturbance in consciousness, and people were thought to be aged between 40 and 90, and there was no other brain disorder that could explain the progressive deficits. Now, these criteria were written in 1984, and for a long time these were the standard criteria. More recently, the criteria have been revised to take into account some of the more recent findings about the basic biology of Alzheimer's disease. The first thing is important to establish the presence of a dementia, that is, a progressive change in cognitive abilities that interferes with social or occupational functioning and represents a change from a previous level of functioning. The dementia, then, is established by a combination of detailed history from the patient and a knowledgeable informant, such as a spouse or a child, and an objective assessment of someone's cognitive ability. The changes should involve at least two domains, including memory, reasoning and problem solving, visual spatial abilities, language, or changes in personality, behavior, or social comportment. What's important to realize is that memory is not an absolute requirement. Although memory is commonly affected in Alzheimer's disease, the diagnosis may be made if two other cognitive domains are present, but memory, at least early on, is relatively preserved. So who should be evaluated for Alzheimer's disease? Well, the greatest risk factor is age, so one could consider that those individuals, particularly those individuals who are Medicare beneficiaries, would benefit from being evaluated. So people with known risk factors besides their age, such as head injury or cardiovascular risk factors, people who come to the office with memory complaints with or without a change that's obvious in their everyday functioning, memory difficulties that may be observed by someone else, such as a close friend, spouse, or relative, and the depressed or anxious patient with or without a memory complaint should be evaluated. What are some of the signs of Alzheimer's disease? Well, at the mild stage, the most prominent feature is forgetfulness. People can have word-finding difficulty. They can repeat themselves, ask the same questions over again. They have poor attention spans. They have difficulty with complex tasks, multitasking. They may have changes in mood, so they can be depressed or anxious, or have apathy, a loss of interest. And if young enough, they can interfere with their ability to complete their occupational functioning. At the moderate stage, these symptoms of the mild stage increase, and we see more disorientation for time and for place. The memory loss becomes much more prominent, and there are episodes of confusion. People may have difficulty sleeping and may wander. They have increased speech difficulty and may become non-fluent. They're increasingly restless and have significant difficulty with their instrumental activities of daily living. At the severe stage, the behavioral features of the disease predominate. People can have aggression and agitation. They can become incontinent and have interference with other basic ADLs. They can have notable gait disturbances. Now, in a research setting, there are a number of ways of assessing people for the presence of Alzheimer's disease. We can measure cognitive function, activities of daily living, and behavior, as well as collecting global measures. The problem is that these scales are somewhat lengthy in time and are not really applicable in the quick office setting, but they are quite valuable in the research setting. So how would one go about doing this in an office setting? Well, the first thing is to get a detailed history. Nothing can replace this. Getting the history from the family and from the patient, and if possible, getting those histories in separate time intervals is helpful, because many times the family may feel uncomfortable talking about some of the patient's deficits. The next to do a comprehensive physical and neurologic examination. This is to look for signs of Parkinson's disease or other extrapyramidal disorders, for cerebral vascular disease, or other physical functioning deficits that could lead to a diagnosis. The next to do a cognitive evaluation. And there are two ways to go about this. One is to interview the patient, collect some global interview about their overall cognitive abilities, or to do a performance test, that is, ask the patient to complete a certain number of tasks. These two different approaches often can work hand in hand to improving the ability to recognize dementia in the office setting. This is followed by doing laboratory work to rule out other medical diseases, and an imaging study, particularly an MRI or a CAT scan of the brain, to rule out other pathologies. In the office setting, the history would include the history of the memory impairment. Do they repeat themselves? Do they have trouble remembering recent conversations, recent events, appointments? Do they frequently misplace objects? We also want to assess further executive abilities. Do they have trouble doing complex tasks? Do they have decreased ability to solve problems and make decisions? Are they impaired in their driving? A drug history is very important, not only for illicit drugs, but for alcohol, prescription medications, and over-the-counter medications. Many over-the-counter medications contain antihistamines or other drugs that can impair cognition in older adults. We want to examine for focal neurological signs as focal findings equal focal pathology until proven otherwise. And we also want to assess for mood changes, behavioral changes, and personality changes. Now, there are many ways to do brief mental status testing in the office. All of these have the advantage of being brief, but they all have limitations, and it's important to understand the limitations of each test. While no test is better than another, they each have weaknesses and strengths that you can utilize in your busy office setting. Let's just review a few of these different types of tests. Probably the most commonly used test today is still the mini mental state examination. This was a cognitive measure developed in 1975. It's brief and well structured. It takes about 10 minutes to administer. However, adjustments need to be made for age, gender, education, and culture. The scores range from 0 to 30, and in general, scores in the high 20s represent normal cognitive abilities. Scores below 24 represent dementia, and scores in between, so 25 to 27, typically reflect those people who are beginning to have mild changes in their cognitive abilities. The typical patient with Alzheimer's disease, untreated, will decline about 3 to 4 points per year. This is important because this can be used as a measure as to whether there's benefit from medication, if there is a slowed deterioration in their mini mental state exam scores. One thing to keep in mind is the mini mental state examination is a copyrighted test, and it requires paying a copyright fee in order to utilize it. The clock drawing test is also a commonly used tool. It's quick, office-based tool. It's very brief, 1 to 5 minutes. It has a minimal language requirement, and since clocks look standardized across multiple cultures, it can be easily adapted for the non-English speaking elderly. It does not require specialized testing materials. Really, it just requires a blank piece of paper. But that is the important point, is that it should be a blank piece of paper. You should not provide the circle for the patient. They should be required to draw a completed circle, that is, the circle is closed, fill in the numbers, and place the hands at the time that you tell them. Two common times that are used are 2:45 and 10 minutes to 11. The important thing to remember also is that you can grade the clock a number of ways. So there are multiple scoring paradigms for the clock. The example on the slide here is a 10-point scale, although for a practical perspective, a clock either being normal or abnormal can be quite helpful. A rapid screen for cognitive impairment is the mini-cog. This takes less than 5 minutes and requires two different tasks. One is a 3-word registration. An example of 3 words would be banana, sunrise, and chair. The words should be unrelated and should have different syllables in the different words. We then ask people to do the clock, and then after completing the clock, ask them to recall the words. If they recall none of the words, they are impaired and the test is over. If they recall all 3 of the words, they are not impaired and the test is over. If they recall 1 to 2 words, then we look at the clock and determine whether that's impaired or not impaired. The diagnostic value of the mini-cog does not appear to be greatly influenced by language or education, and is a highly sensitive and specific test to pick up cognitive impairments. Another example of a brief test is the Montreal Cognitive Assessment, or MoCA. This is a 30-point scale. It takes about 10 minutes to administer and was originally designed to detect mild cognitive impairment. It's a little more advanced than the mini mental state examination, as it has not only memory tasks but attention and executive ability tasks. A score less than 26 suggests cognitive impairment. Its utility has been demonstrated both in an office setting and in other diseases such as Parkinson-related dementia. It is freely available for clinicians to use at the website listed below. An example of the MoCA again can be seen in this Try This demonstration from the Hartford Institute of Geriatric Nursing. Besides a performance test, we can also get an interview or an informant assessment. An example of this would be the AD8. The AD8 is an 8-item yes-no questionnaire that can be filled out by the informant, or, if not available, the patient can also fill it out. And the idea is that you want to detect change in an individual compared to their previous level of function. Thus, there is no need for a baseline assessment because each person serves with their own control, is therefore not biased by education, race, or gender. It's brief, taking about 2 minutes to complete, and again is 8 yes-no questions. 2 or more yeses are highly correlated with the presence of dementia. These are the questions for the AD8, and you can see again that there are 8 simple questions, and you're looking for a change, and that's really the key, is to make sure that there's a change. If someone has always repeated themselves, for example, then that would be no change. The AD8 has very good properties as an interview. It's able to discriminate individuals who have even the mildest forms of dementia with a very large effect size. It works across multiple different dementia diagnoses and is highly correlated with biomarkers such as MRI changes. If one were to combine a brief informant interview with a brief performance task, you tend to increase the ability to pick up disease. So for example, in the receiver operator characteristics curves shown in the lower left-hand corner of this slide, we can see that the AD8 plus a word list recall can detect about 97% of people who have dementia and 91% of people who have mild cognitive impairment. The AD8 is also culturally sensitive, as can be translated into numerous languages, and this is the Spanish version of the AD8. Another thing that's valuable is to not only assess cognition, but to look at activities of daily living. There are a number of scales available. One such scale is the Functional Activity Questionnaire. And so this is 10 questions, and people are asked to rate whether there's an increase in difficulty performing the task. Another example would be to assess instrumental activities of daily living using this scale from Lawson and Brody. Now the scale is a little bit old, and so it doesn't always translate as well as some of the newer scales that have been developed, but can be quite good at looking at whether someone is developing a dependency in their activities of daily living. We can look at laboratory evaluation. So, for example, if not done recently, a complete laboratory exam is warranted, as changes in hemoglobin, electrolytes, liver function, thyroid function, B12 levels can all potentially be associated with cognitive difficulties. The general recommendation is not to do syphilis screening unless there's a specific risk. However, the challenge with this is that the risk for most individuals would have occurred many years ago, and they may not recall that risk. So it's up to the clinician's decision as to whether they would screen someone for syphilis. At the present time, there's no value in a clinical setting for doing genetic testing or ApoE4 genotyping. While these are valuable research tools, it is unclear what they add to the clinical diagnosis. Also, at the present time, no cerebral spinal fluid or serum biomarkers have established clinical validity. CSF biomarkers may assist in the differential diagnosis. Again, the question is whether to image or not. A non-contrast CT or MRI scan is indicated in the initial evaluation. This is an American Academy of Neurology guideline. One of the values of imaging is to rule out other forms of intracranial pathologies that may be contributing to cognitive change, or if someone has an unusual presentation. PET images may also be helpful. There are 2 types of PETs that may be indicated. The first is a fluorodeoxyglucose PET. This looks at brain metabolism and is indicated by Center for Medicare Services to differentiate Alzheimer's disease from another type of dementia called frontotemporal degeneration. More recently, the FDA has approved amyloid imaging with a compound called florbetapir. If someone has increased florbetapir uptake in their brain and has a cognitive decline, it is highly likely that the cause of the cognitive decline is Alzheimer's disease. Let's just quickly review some of the changes that you can see in neuroimaging. This is MRI from 3 different individuals. Coronal scans are showing the hippocampus, which appears normal on the left, and shows mild changes of atrophy in the mild cognitive impairment individual in the middle, and more notable atrophy on the right for those individuals who have Alzheimer's disease. We also can see that the ventricles become more dilated as there is cerebral atrophy. One of the newer findings in terms of the research in Alzheimer's disease is the use of biomarkers. What exactly is a biomarker? It's simply a measurement that corresponds to something. It can correspond to the probability of disease. That means it helps you make prediction of disease. It can correspond to the presence of disease, then this way it can be used as a diagnostic tool, or you can use it to follow progression of disease for monitoring. Now, a biomarker may fill one, two, or all three of these categories. There are many potential sources for biomarkers. For example, we potentially can use spinal fluid to measure amyloid protein, which is found in the senile plaque, or tau protein, which is found in the neurofibrillary tangle in the Alzheimer brain. We can also measure a number of inflammatory markers. We can measure amyloid and tau in the blood, although this has less clear clinical correlation than the spinal fluid. There are genetic biomarkers such as the apolipoprotein E. And lastly, as I mentioned, imaging biomarkers. Let's quickly review some of the data that's available. We can do structural MRI, and in a research setting, parts of the MRI can be extracted out and developed on a computer template so we can study the size, shape, and surface area of individual parts of the brain. Also, with MRI, we can do something called functional MRI that allows us to look at connections between different regions of the brain during a particular task or at rest. We can do PET scans looking at brain metabolism, or, as I mentioned before, there are newer PET scans where we can look at amyloid imaging to look at pathology. What's interesting is that all of these different approaches to looking at the brain are highly correlated. What you can hopefully take away from this picture is that areas of the brain that show changes in structure also show the same changes in function, and this is the same areas where we see changes in brain metabolism and deposition of amyloid. So these biomarkers are highly intercorrelated. We can also use spinal fluid, particularly to predict progression. So if we see somebody who is normal and has an abnormal biomarker, they have a 4 to 5-fold increased risk of converting to a dementia over the next few years. This next slide just reiterates what I said, is we can look at structural imaging, functional imaging, brain pathology, and metabolism, and these are highly correlated. They're occurring in the same exact area. So these biomarkers are giving us a very good sense in a living person of the changes that are occurring in the brain. And in the next few years, there'll be increased use of biomarkers extending not only from research but into clinical practice. So let's step back now and look at a sort of a stepwise approach to assessing Alzheimer's disease in the office setting. The first step is to figure out what that pre-diagnostic test would look like. You're going to do a history, do a physical, you're going to establish that differential diagnosis and determine whether there are other coexistent disorders. So you'll do your medical history, that lab work, look for some of the early warning signs such as published by the Alzheimer's Association, look at your risk factor assessment. Next, you want to assess performance of the patient. So you want to give them a cognitive assessment to see whether they have a change suggestive of Alzheimer's disease. You can do this by performance, giving the mini mental state, the mini cog, the MoCA, as well as an interview, such as using the AD8. Next, you want to assess their daily function, because you want to see what level of independence or disability there is, and we gave you some examples, such as measuring instrumental activities of daily living, or the functional assessment questionnaire. You want to assess for behavioral symptoms. Behavioral symptoms can be quite disturbing to the family. There are short behavioral tools such as the neuropsychiatric inventory. Next, you want to assess the caregiver and figure out their needs. The caregiver is part of the care team, and as you take care of the patient, you will find that you are really taking care of the patient and the caregiver. So you want to establish collaboration and assess the adequacy of the support systems that the patient has. And lastly, you want to take into consideration special things such as language, culture, the health literacy of the patient and the caregiver, because if they do not understand what you're talking about, they're less likely to follow through with your recommendations. We next present sort of a schematic for the long-term follow-up. The first step, of course, is to screen all elderly individuals with a memory complaint. You want to diagnose and then treat. If someone is at the mild stage, you would want to consider treatment with an approved medicine such as a cholinesterase inhibitor. At the moderate stage, you may want to consider treatment with combination therapy of a cholinesterase inhibitor plus memantine. At the severe stage, you would also want to consider combination therapy. As people progress, if they're on monotherapy, you'd want to consider adding an additional agent. And you also want to always consider when to discontinue therapy, really when patients advance to a state that they lose all their cognitive and functional abilities and you do, in your clinical opinion, are no longer gaining any benefit from treatment. As part of this, though, in the long-term follow-up, you really want to perform ongoing monitoring and evaluation. You want to reevaluate the patient in a 2 to 3 month period after first starting a new medicine, and then monitor them every 6 months or so. You want to provide care and counseling for patients and their caregivers and set realistic treatment expectations. You always want to consider, particularly if the patient or the caregiver reports a change, whether there is some other reversible medical cause of the types of changes that they're exhibiting. And you want to provide that geriatric care management and counseling and refer people for community resources such as the Alzheimer's Association. Let's now turn our attention to some of the behavioral symptoms in dementia. What I have here are a cluster of symptoms that are associated behaviors that we see in Alzheimer's disease and related disorders. And they are clustered in terms of groups because it's important because the approach to each of these groups of symptoms is quite different. So, for example, we have the aggression subgroup, and this is the aggressive resistance, physical aggression, and verbal aggression that sometimes we can see in patients. And the approaches to this would be very different than the approaches in more of the psychomotor agitation types of symptoms. This is wandering aimlessly, pacing, trailing the caregiver around, feeling restless, doing stereotyped or repetitive actions, having trouble dressing and undressing, and having sleep disturbances, insomnia, for example. Another cluster of symptoms are the psychotic symptoms. These include hallucinations, delusions, and misidentifications. There are the specific sleep parasomnias that have been associated with dementias, including REM sleep behavior disorder and periodic leg movements of sleep. And then we have mood symptoms, and we break them into two clusters. The first are the depression cluster. This includes people who have both depression and anxiety. They have many of the symptoms of depression. They're sad, tearful, hopeless. They have a low self-esteem or guilt. And this is different than the apathy cluster, which are people who tend to become withdrawn, show lack of motivation, and a lack of interest in their previous activities. The reason we break these down into clusters is because some symptoms are responsive to medications where others are not, and so this gives you a sense of how one could approach these symptoms from a non-pharmacological perspective. So for the apathies, what you really want to do is engage them in an activity therapy to try to improve their interest in what's going on around them. For depression, there is cognitive therapy and cognitive stimulation. There may be a number of behavioral interventions, including therapeutic activity, music therapy, for example. For those people who have these parasomnias, music therapy and bright light therapy and or melatonin may be an appropriate approach to addressing some of these disorders. For the psychosis, besides looking at their current medications and deciding whether those need to be changed, go back and look and see if they have a visual or hearing impairment. This could contribute significantly to them seeing or misinterpreting information. Want to improve the light conditions. Hallucinations tend to occur more frequently in dim light settings. And you want to try to modify the patient environment. For wandering, psychomotor agitation kind of activities, you want to try to manage the surroundings. For example, covering a door with a poster or a drape may prevent a person from trying to leave because they do not see a door. For the aggression or agitation, thinking about therapies such as therapeutic touch or multi-sensory stimulation, Montessori-based activities can have a significant impact in reducing some of these behavioral symptoms. So these non-pharmacological approaches can be effective, but they need to be implemented in a systematic fashion. So to summarize, the first point I want to make sure that you leave with is that memory loss is not part of the normal aging process. In people who are not developing a dementia, they generally have stable cognition, although they may do things slower. If they have a memory problem, something is causing it, and it's up to you as the provider to figure out what that is. Mild cognitive impairment may represent a prodromal stage of Alzheimer's disease. Knowing this, we can now make diagnosis of Alzheimer's disease clinically at earlier stages and starting treatment when they'll be most effective. Using brief performance and interview methods that we discussed today will assist in the detection of Alzheimer's disease, and eventually biomarkers will improve our ability to diagnose the disease at even earlier stages. I want to thank you for your attention and congratulations on the completion of this module.